The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead.
Welcome to Project Independence and You.
Good morning and welcome to Community Talk Radio. This is Project Independence and You on LIU Public Radio. I'm your host and producer, Kristina Liu, along with co-host Otto Los and Paula Ewell. Paul and I work together at the Department of Services for the Aging at the town of North Hempstead. And Otto, of course, is our senior extraordinaire. I mean, he's everything to us. This morning, we are talking to Dr. Carney, who is the Chief Division Geriatrics and Palliative Medicine Medical Director, Continuing Care Professor, Zucker School of Medicine at Hofstra and Northwell Health Department of Medicine, and co-author of The Aging Revolution. We also have Kaitlin Emmert, who is an LMSW, social worker, dementia care assistant, geriatrics, and palliative medicine. So we have a jam-packed show today. Thank both of you ladies for joining us. We're going to talk about a new initiative that Northwell Health is doing, which is the GUIDE program, which is guiding an improved dementia experience. It's all about how a new program for people living with dementia and their caregivers as well. And of course, we're going to dive into the book, The Aging Revolution, and all other things aging. So thank you both for joining us.
Thank you very much for inviting us. Happy to be here.
Great. I'm so glad. And Kaitlin, welcome too. Caitlin's virtual in this, so we have all of us in different places today.
Yes, thank you for having me.
Yeah, so I would love to dive in. You know, of course, we saw the Newsday article about how Northwell got from CMS the GUIDE program funding. So I'd love to know all about that, what it is. Just start from the beginning.
Sure, I will start and then Kaitlin, you can add. The GUIDE model is a specific program out of the Centers of Medicare and Medicaid Services, known as CMS, where we are piloting this, where we are caring for individuals with a diagnosis of dementia along their journey and helping them link to resources in the community, manage their medical issues, as well as managing their dementia illness. As we know, dementia is very complex. It can affect many people in many different ways. And it's not only about the patient, but it's their family. And so with this program that has quite clear criteria and goals, we are working to help patients and their families with dementia.
I guess one of the first questions is, when do you define that it's really dementia as opposed to like MCI, right? Mild cognitive impairment?
Really great question, because there is a natural decline in memory as we age. I think of it like having a bookshelf and having books on it. And as we get older, more information, memories are created. And it's hard to retain that information. Where it becomes dementia is when your ability to function is impaired. So if you were cooking and you had this recipe that you knew like the back of your hand and you did it, and then all of a sudden one day you can't complete that recipe, or you're writing bills and you were an accountant and you were doing your bills over decades, and then you start having difficulty with doing bills. So it's when function starts to be impaired, and it's not labeled at dementia until you rule out other causes. So you have to have a comprehensive assessment, make sure you're not suffering with other medical illness, thyroid, infections, vitamin deficiencies. Have you had trauma to the brain? Do you have any attention deficit disorders? Are you drinking alcohol? Have you had little strokes in the brain? So are there medical issues, illnesses that will help explain this change in memory, and how impactful is that memory loss in your day-to-day function. And that's what helps define a dementia.
Which I think the family probably knows better than the doctor, no matter which doctor you get involved with.
A lot of the information we get when we talk to patients and families is through the family.
Right. And the difficulty of the family communicating with the person who has these symptoms can be touchy.
Yes.
But from witnessing, it's a very good thing to be able to get to the point where you can communicate openly about the fact that this person is having difficulty in terms of cognitive function, like you said, functionality.
If we assess the person for memory problems, and we've found that there are certain things we can treat, we can then follow and see if we're making progress and improving the memory or minimizing the loss. We don't easily come to a label of dementia. It may take several visits.
Right.
But then once somebody is identified to having a dementia, that's like an umbrella term.
Right.
There are different types of dementia: Alzheimer's, vascular, Lewy body, frontotemporal, and they all present differently and have different courses. So part of caring for a person with dementia is to help through different stages, maximize treatments, support the family in providing the best care. And I think a lot of the time we spend is educating that this is a brain disease.
Right.
And it's sometimes hard for families to see this as a brain disease.
And society, actually.
Yeah.
And society.
Yeah, I mean, it's like a lot of things that happen to people. There are sometimes a stigmas connected to them. And just like any other mental health issue, this is a disease that hits people of all intelligence. It's tough stuff. But with your program now, we're now getting to where, okay, through whatever the process is, it's defined that this person has some form of dementia.
Mm-hmm.
What does guide now do? When all of a sudden you qualify?
You qualify.
Right. How does it work after that?
So there is a certain number of visits, regular visits, to stay in touch to help the patient and family through this journey. There is the dementia care specialist that helps the patient and the family understand the disease and the process. There's an assessment of their home, their care needs, and when needed, there's a limited amount, but there is a resource of help for families for respite services. Kaitlin, I don't know if you want to explain a little bit more about your role as a dementia care specialist.
Sure. I just think one
Oh, Kaitlin, you're a little broken up. You're a little choppy.
Okay, I'm going to turn my camera off. Can you hear me a little better now?
Yes, we hear you now.
Okay. So we're at Northwell, one of the 96 established sites across the country to implement this program. Over the course of the next 2 years, there's going to be 400 other sites, but we're very lucky to be one of those initial sites piloting this program, and be part of, on the ground floor to see what's going to work, what's going to need improvement. And I think, Otto, what you said, really the fact that this is coming to the spotlight nationally, right? Dementia has been happening behind the scenes for a lot of people. It's very unrecognized for families. They're going through this alone. And now Medicare is taking this opportunity to say, this is a really important issue and we need to spotlight it and provide these services that really have not been provided before. And so that's our role here too, is we're supporting the families, we're helping them through this diagnosis, we're giving them the resources that they need to live at home successfully, as well as figuring out what their goals are in their care. A lot of that is advanced care planning, figuring out if their goal is to live at home, if not, connecting them to the services that they need, maybe doing a hospice referral down the line to get them those additional services, and educating and really supporting that family along the way. So giving them the tools that they need for a successful dementia journey. And that's kind of what this program is.
Medicare.
It is.
There's no charge to the program, I understand, or there is a charge?
It is for Medicare fee-for-service beneficiaries,
right,
not Medicare Advantage. Right. Individuals with Medicare Advantage plans are excluded. It is a payment system to our group.
You get paid.
We get paid right. to care for people, longer visits, more time, which was never done before. Right. So we have more dedicated time and healthcare resources to spend with the patient and family.
Okay. And Northwell is who is one of the providers?
Our office
right.
in the Division of Geriatrics Palliative Medicine in New Hyde Park is where we are holding the guide program. We are starting with a limited number of zip codes around our office. We're going to get this going, show its benefit, and then our goal is to expand.
Is it like I know my zip code 11040 happens to be on the list, so now I have more of an interest, obviously. When you kick this off, like, you know, you have visits, describe how that might work. Like the visits are what? You go to a place, or people come to you, or?
So we've been doing this for several years. We held what's called an Alzheimer's Dementia Care Program, which was in partnership with UCLA, which is actually a predecessor to the guide model. So what we have done, and we will continue to do, is we assess people who say, you know, I think I'm having some memory problems, or something's not quite right. And we do comprehensive geriatric assessments, basically comprehensive assessments. And it may include questioning about memory, mood, mobility, medications, what matters most to you, and really get an understanding of your baseline function and what's changed. And through that assessment, we may say, you know, this is what we recommend: testing, blood tests, perhaps MRI or CAT scan of the brain. It may take an hour or an hour and a half for the first visit to do a comprehensive assessment. And then we'll talk to family, caregivers, other doctors, and then come to a consensus of a diagnosis or care plan, and whether someone qualifies for the guide model or not.
What if your primary care physician is not connected with Northwell?
It's for anybody.
So you could still...
Yes. Yes.
You know, obviously we have a lot of different systems around this part of the world, fortunately.
Yes.
We can't lack for health around here. Health support, I'd say. All right.
Yeah. You don't have to relinquish your primary care physician to be part of a guide model or to get a comprehensive assessment in our office. We can do a consultation, say, yep, you're being cared for very well. We wouldn't change anything.
That's great.
And you can go back to your primary care physician. And have individuals come from far away, destination site, for that reason, just to say, you know, I have multiple medical problems. I'm on a lot of medications. And we look at the 4 M's: mentation, medications, mobility, and what matters most.
Yeah.
Yeah, you added a couple to the ones I always say on here. Talk about M&Ms, mind and mobility.
Yep.
That's right. You got to add. You got to MMM.
Through
The 4 M's.
we don't have M&Ms anymore.
That's right. You got to change your slogan there. Otto. But now, Dr. Carney, for this, so what is the first, like, if someone's thinking about the guide program or just wants to get this comprehensive assessment, what's like a good mode to get in touch with you? Would it be a phone?
Yeah. Call our office, 516-708-2520. We have 8 physicians, 2 nurse practitioners that are geriatricians or geriatrics and palliative medicine. And really our goal is to comprehensively assess and looking at those 4 M's:
Right.
mentation, medications, mobility, and what matters most. Because if you have multiple problems, treating one thing may affect another thing. So it's often, you have to understand what's most important to you. Is it mobility, independence, safety? Is it being pain-free? And so you can tailor a care plan based on what matters most.
Yeah, that's great.
That's
And along with this guide program as well is built-in caregiver support. And it's very important to acknowledge that, especially geriatric populations, they're not just a person living alone, or if they are, they probably shouldn't be. They have a caregiver, and we, as our office, we assist with the caregiver. We help provide resources for them and provide them the support, because caring for the caregiver also helps care for that geriatric patient as well.
And I definitely want to dive into the caregiver support, but we're going to take a quick break. We're going to continue talking with Dr. Maria Carney and Kaitlin Emmert, who are both from Northwell Health, Division of Geriatrics and Palliative Medicine. And we're going to talk more about this guide program and, of course, the book, The Aging Revolution. You're listening to Project Independence in You on LIU Public Radio.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
Welcome back to Project Independence in You on LIU Public Radio. I'm your host, Kristina Liu, along with my co-hosts, Paula Ewell and Otto Los. We're going to continue talking with Dr. Carney and Kaitlin Emmert, who are from Northwell Health, Division of Geriatrics, Palliative Medicine. We are talking about this great new initiative that Northwell is involved in called the Guide Program. And prior to the break, we were diving into that in addition to everything that the guide program does for the patient, it's really also geared towards the caregivers, which certainly we talk about quite often on the show, are often neglected. They don't realize that they are a caregiver and need all this support. And I think that it's so much to take on. And I loved what really sparked this, my interest in this program was the 24/7 hotline that they could talk to. So what would you call, what would a caregiver call the hotline number for?
So our office has 24/7 coverage by specialized, trained geriatric physicians.
That's great.
So caregivers are often not sure if there's a crisis ahead of them. There's a change in behavior, medications were taken wrongly. There may be a medical problem that's occurring, that individuals with dementia may not get the fever or pain. They may just get a change in behavior. So some caregivers will call, is there something wrong? Is this a part of the disease or something happened? I don't want to take them to the hospital because that can be very traumatic at times, but I will take them to the hospital. I need guidance on whether to go or not. And then caregivers will be like, I have a wedding to go to.
Right. They have their lives, it's hard. Yeah.
How do I get help? I'm entering a new stage of disease with my loved one. I'm going to need some help. Is there help for me to have? So those are the type of questions. And Kaitlin Emmert, our social worker with the guide program, can explain further other calls they may get from a resource point of view.
I think it's something that we often forget working so immersed in healthcare and with this population. I joke, when I do my taxes, it's a whole different world for me because I don't know anything about it. Healthcare for us, it seems so innate and so self-explanatory. But for a lot of people who are going through this, they may have no idea anything about medicine, anything about healthcare. They've never been a caregiver before. They've never even heard the word dementia before. And so a lot of the time it's providing them that education from whatever level they are at, right? And then it's meeting the caregiver or the person where they're at. It's a very scary disease, and it is a terminal illness. And a lot of people, aren't prepared for that kind of to take on this kind of really new role in their lives. So providing the support for that, and providing education and all the tools that you need to get through this and successfully, as well as still having a good quality of life. So another portion of this program is connecting them with things like day programs, home health services, giving a person living with dementia a purpose again, and separating them from just being their disease to giving them, you are living with a disease. You are not your disease. So all of this is really ingrained in this program. It's been what we've been doing in our office for, many years through the Alzheimer's and Dementia Care program. But now this is, again, just Medicare spotlighting this type of program.
In preparing for this, I read one term called care navigator.
Yeah.
Yes.
It sounds like this is like a person, your go-to person who kind of guides you. How does that work?
Yeah. A care navigator is a new term that has come out in healthcare.
Right.
Healthcare is very complex. And if somebody has dementia, they probably have other medical problems too.
Right.
And so a care navigator will help prioritize for the family which doctor or test to go to and how to coordinate it easier for the family.
Is this like a person who's assigned to your
part of this program?
Your case, if you will.
Yes.
Yeah.
I do want to go back to something, Kristina, you said, that caregivers often don't even realize they are caregivers.
Right. That's my husband. That's my mom,
It's my husband, my daughter, my son. I'm not a caregiver.
Yeah.
And sometimes they don't want to acknowledge or can acknowledge or just don't see that they have care needs, right? So we want to acknowledge the caregiver role because we as physicians are making care plans for somebody with multiple problems. And if we make it too difficult for the caregiver, if they're implementing it, then we're going to fail.
Yeah, absolutely.
And the care plan will fall apart and the individual will potentially end up in the hospital, and we don't want that.
Yeah.
So a big part is to acknowledge who is providing care, make sure they're involved in the care plan decision-making, along with the healthcare proxy if we need that, or with the patient wishes. I should have said that first.
Yeah.
And it's all aligned. That's not easy.
Yeah.
And a care navigator, once a care plan is established, can kind of help the family implement it.
I think it's safe to say also that all caregivers are different. Like some caregivers are active, some caregivers are really not active, so they have a lot more time to give.
And sometimes it's not just one person.
Right.
Yeah, right. It's
Sometimes
team,
it's 4
family,
people,
right,
in different roles. And it's hard to make sure it's consistent. Very hard. And sometimes also teenagers or children that are also helping.
Well, it depends on in my case, I have a granddaughter who's a social worker. So
you're blessed.
Yeah, very blessed. And the other 2 daughters are also of that mentality. So we are very fortunate that we have people who would be available if we ever need them.
Yeah. And some people are involved, caregivers have healthcare experience, and some people are completely naive or new to healthcare. So there's a lot of education that is needed.
Yeah, I mean, we talk about that on the show all the time, preparing for doctor visits. Don't just walk in there like you expect the doctor to look at you and know what's wrong. You have to tell them what's happening. And some people are good at that and some aren't. Yeah. So if you're a caregiver and you don't have a little of that going on in the first place, I think your program really would help greatly, even for people who do know what's going on.
Yeah. And when it becomes your problem, sometimes it feels different too. You might know a lot, but when it's your loved one and you're now the caregiver, it takes on a different feeling. And what I wanted to ask Kaitlin about are the respite services, because through Project Independence, we work with family and children's to offer respite services, but they're underutilized. So I'm wondering, Kaitlin, if you have any suggestion or how to best explain to people how they can utilize that service.
Yeah, definitely. And we see this happen in our office all the time, especially when it comes to home health services. There's a misconception that I would say that taking on a home health aide, right? Having somebody come into your house to provide that extra level of help, maybe they do some cooking, some light cleaning, some help with the bathing, bathroom, toileting, things like that. People view that as a loss of their own independence, where that misconception is really you can have more independence if you reach out for help earlier.
Right.
And if you use these services, it's an extra hand in the pot helping, right? It's if you get help earlier on, you're actually going to need less help in the long run. And you'll probably end up being more independent by taking on that additional help, because you're not having to be doing all of this on your own. Yeah. And I think that's the most important thing to acknowledge. Even like doing little things like, home health aides are one example, right? If you can, get help with meal deliveries, things like that, especially as a caregiver. These are all tasks that we're taking on that are just one thing after another that we're trying to figure out, we're trying to deal with, along with the emotional component as well. It's so overwhelming. Yeah. So taking on this extra support, figuring out, what can I delegate, and then using that respite, right? Taking a break when you need it. You don't want to be too overwhelmed to the point that you're just like, I can't do this anymore.
And that what's the care navigator would help set that up?
Yeah, so our program is partnering with Northwell Health at Home for our respite services. Again, to highlight with this program, it's a very, very small respite service allowance for a small amount of people in the program. Okay. The unfortunate truth with dementia care across the board, it is very expensive. But utilizing, the expense of getting these respite services, it might be very hard out of the pocket in the short term. In the long run, you might be saving yourself like needing to be in a nursing home earlier than expected, if that makes a little sense.
Yes. I will say
Dr. Gordon, yes,
there are, because of the dementia care specialist program, there are resources available that many people don't necessarily understand exist. Right. Community resources Again, not a lot, but there are some.
Well, I think there's a stigma in some circles that it's charity, and I don't need charity.
No.
And I think a very big point was brought up by Kaitlin also about you have to give up some independence to keep more independence.
Yeah.
If you don't give up some of it, you're going to lose all of it.
And there's a reality that this is a marathon for many families.
Right.
And you have to take care of yourself in order to care for your loved one. Right.
Which may appear selfish, but the bottom line is you do, in my opinion, you have to maintain some degree of mental and physical strength in order to handle what is going to go on around you.
Yes.
And we also do still want to have a good quality of life.
Shortcuts.
Right. Just having a diagnosis like this, we don't want to give up who we are as a person or who that person was. So figuring out, taking on these additional help, you can find yourself again as a person, and as a caregiver.
Yeah. So part of the team, Kaitlin, someone is assigned a care navigator, and that person is usually a social worker.
So we also have nurse practitioners who are acting as care navigators, and working in a interdisciplinary team is the way that we're approaching this. And I think it's really important because, social workers can't do the medicine piece.
Right.
The nurse practitioners maybe aren't, or the doctors, physicians, geriatricians aren't doing the social piece as much. But all of us together really bring our perspective, our expertise to provide all of the needed services.
Yeah. Thank you.
Yeah, and I think, so huge, I know in working in Project Independence too is, when you have, we always say it's our circle of support where everyone kind of gets on board and plan things. And that's really how the best plans really can work. So I think that kind of thing, that's what I love that you said, that you asked them, what is your goal?
Right.
So it's not saying, okay, like, listen, you have this diagnosis.
Yes, this is person-centered. I'm not sure you can hear me here.
Mm-hmm.
Yeah, this is person-centered care, but we have to include the support team around that individual and try to make it as close to what their goals are as possible.
Yeah, it's incredible. It's really. And then, so is there a certain time frame that someone can be part of this program? Is it like,
they have to have to be part of this program, they have to have a diagnosis of dementia.
I got you.
That is a requirement. And within certain zip codes, because we're starting this small, and then they have to be on a Medicare fee-for-service, not Medicare Advantage or private insurance. This is just Medicare, plain Medicare.
No Medigap or none of that gets involved.
It's
Medigap, if they have an additional insurance, that's okay, but Medicare.
Right.
And the only other one is also Medicare Railroad.
What is that?
So
it's for
CMS, plain Medicare that you can register for. It used to be that the majority of individuals just had plain Medicare, but now there's insurance companies coming into the Medicare program, and those are called Medicare Advantage programs. So United Health or some other insurances. And so it is not the Medicare Advantage product. It's just fee-for-service Medicare program.
Yeah, the Advantage plan kind of overrides Medicare, I think. They're taking the place of Medicare.
Yes. And
whereas Medigap insurance is supplementing the real Medicare.
Yes. And
I don't think people understand that a lot of times.
So actually we discuss this change in Medicare in the book, The Aging Revolution. There's a chapter about right before our eyes, Medicare has evolved. There used to be that 80%, 90% of individuals were just Medicare. Now it's approaching 50% of the population is Medicare Advantage, which the goal was to save funding, decrease the cost of care. We're not sure that's actually happening when you look at the data about Medicare Advantage, but it requires people to be in narrow networks.
Well, we've had people on the show about that.
Well, Otto, you're gonna have to hold that thought because after the break, we're gonna continue talking with Dr. Maria Carney and Kaitlin Emmert, who are from Northwell Health Division of Geriatrics and Palliative Medicine, and we are going to talk about the GUIDE program and the book Aging Revolution. Well, you're listening to Project Independence and You on LIU Public Radio.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence and You on LIU Public Radio. I'm your host, Kristina Liu, and my co-hosts, Paula Ewell and Otto Los. And we are having an amazing conversation with Dr. Maria Carney and Kaitlin Emmert from Northwell Health, talking about the GUIDE program. And Kaitlin, before you go, I would just love to know if someone is interested in finding out more information. Is there a phone number or a website that our listeners can go to?
Sure. You can always give our office a call at 516-708-2520, and our Northwell Geriatric and Palliative Medicine website. If you just Google Northwell Geriatrics and Palliative Medicine, has that direct phone number on it as well.
Perfect.
Great. And thank you so much for having me. This is a wonderful.
Yes, well, you certainly will be hearing more from us, Kaitlin, our social workers and nurses. We're going to tell about this program, so we will definitely be in touch more about this. So thank you so much for joining us, Kaitlin.
Thank you, Kaitlin.
Thank you. Bye-bye, everyone.
Take care.
Bye.
Well, Dr. Carney, I mean, there is so much we could talk to you about. We're so happy that we got to do this, and now we get to kind of segue into your book that you co-wrote. If anyone is watching this on video, it's called The Aging Revolution: The History of Geriatric Healthcare and What Really Matters to Older Adults. You co-wrote this with Michael Dowling and Charles Kenny. So give us a little overview of this book or how it came about.
Yeah, I'd love to. So one day about 2 years ago, I got a call from Michael Dowling's office that he would like a presentation about all the aging services at Northwell Health and what are the challenges moving forward for this growing population with longevity and chapter of life we are facing. So he said I could bring anybody, and there was a team of us of about 8 people, and we each had a different topic and case to present. And that's how it came about. And it actually started somewhat of the outline for this book. So each presentation really represents almost a chapter, and that led to interviews. So Charles Kenny and I did hundreds of hours of interviews of leaders in this healthcare space of caring for older adults. And so some of the topics in the book, the chapters, we talk about Robert Butler, Dr. Butler, who was
so impressed.
Yeah, I know.
When we started social work school, that was the first.
He was my chair of my fellowship program at Mount Sinai, a real gentleman, founding director of the National Institutes of Aging. He founded the Department of Geriatrics at Mount Sinai, which is now the Department of Geriatrics and Palliative Medicine at Mount Sinai. We interviewed Chris Castle, Diane Meyer, regarding their experience in developing that department. We have a chapter on caregivers, and we talked with Susan Reinhardt of AARP Public Policy and her work in elevating the importance of caregiving and caregivers in healthcare. We talk about age-friendly health systems with leaders of IHI, Kedar Mate, who wrote a foreword in the book, and Terry Fulmer, the director, CEO of the John A. Hartford Foundation, which is an amazing foundation that focuses on older adults and those with serious illness. We talk about Medicare changes, the #1 government insurance for older adults that really revolutionize healthcare as we get older for 65 and older individuals. And we all love Medicare, but there's been changes going on and it's incredibly complex. So there's a chapter about that. We talk about the healthcare industrial complex and the cost of healthcare and how primary care is not keeping up with the needs of this growing population with multiple chronic conditions, right? Primary care today, you have to see a patient 15 minutes, but you can't really
assess the situation. Yeah.
So we really have to revolutionize primary care so that we help, so that the emergency department isn't really primary care for many people.
Yeah.
We talk about care at home, how that needs to increase. More and more people are really limited to home because they can't get out and about unless they have somebody to take them. So we are at a critical time in healthcare. And this book is different. And I'm sorry, I can keep talking, but
no, please, absolutely.
You're enthused.
Yeah.
This book is different because there's so many books out there about what you can do individually for yourself and aging. But this talks about healthcare
as a whole.
And the importance and the accomplishments that have been made over the years. So the history, and then it starts moving towards what we need to do in the future. And I really applaud Michael Dowling. He's such an inspirational leader to have tackled this, started the discussion, and then this book came out of it. So I really thank you for letting me come on today.
It's so, it's so important. And, Paul and I were talking, we were so happy. You've done a lot with Project Independence. You've talked at our conferences. And I think that, having Northwell as our partner in so many realms of things, and all these wonderful health systems, it's really looking at aging, as a different way and what needs to happen, it's, especially, we're constantly trying to think of new time, and I remember we would talk about, the elder orphans and how to reach out to that population, so it's this, we're very fortunate in our community that we have, all these players who are really trying to, make things better, essentially, and how to go about that and the conversations that need to happen.
Like many things in life, the devil is in the details. And there are some things that you have where I didn't realize, like if somebody comes into Northwell, you have a hearing device that helps people who can't hear. I'm conscious of that because I wear hearing aids. But as they know, I happen to be a bit of a fanatic about keeping, my family all has a complete record that if they have to go to an emergency room, one of the things is,
if everyone was like Otto, we'd be.
Well, one of the things is I can't hear well. So if I'm in there and you're talking to me and I don't know what you're saying, it impacts my health. And, just things like that can be considerate about. You can't hear, maybe you can't see too good, all kinds of different things that happen when you get older or even when you're young.
It's true. I remember when I was a fellow, one of the things I learned was when you examine a patient, and as we get older, some of our senses decrease, our vision, hearing, but skin is usually intact. So when you see a patient, they may not be able to see you as well or hear you, and it's frightening in a hospital setting. So just touch them on the shoulder, gently, just a reassurance, and then rather than just going in and examining them. Yeah. So it's simple things like that. We want to educate our new learners in healthcare about aging. And aging is not a negative, right? We have to make sure we
always say
negative.
That's the goal, right? The goal is for all of us to age, right?
Right. It's longevity, it's independence, it's maintaining that independence safely, high quality of life, being productive, impactful. I mean, you're an example of your volunteerism and being involved, how you help your community. It's like incredible, and being purposeful. And that's the beauty of the longevity we have had in our healthcare or in our society. But then there's some downsides to longevity that we have to understand, that there's a lot of treatments out there. There's a lot of procedures. And when is it right or not right to say, don't do something in healthcare. And those that gets complex. But we've nearly doubled a lifespan in 100 years. In 1900, someone born was expected to live to about 45. 2000, it's approaching 80s. And now in 2024, there's a real possibility that you can live to above 120. So we're learning
I
a
mean, I'm
lot.
gonna be doing this for
That's right, Otto. You heard it here.
years.
Dr. Carney told it here first.
So there's a lot of productivity that can be there, and we can work longer, and we can share our wisdom. It's not, I want to make sure that when we talk about aging, it's not all negative.
That's, I believe that to hold true on both sides. In other words, the people who are getting older have to, and I never use the word older, because we're all getting older just sitting here. It's a fact.
It's a fact.
So the people who are getting older have to start to think a little bit differently about things. And the people who try to get you to be older in the health field, that medical field, some are good at it and some aren't too good at it, just like everything in life. All right.
There's a lot of ageism in society, right? Externally, but there's also a lot of ageism
internally, right?
Internal self-ageism that we have got to fight that, just as you said.
Yeah, I mean, I have friends, frankly, that have been old since they were 40. I mean, it's a mentality.
It's a mentality.
That, well, I'm getting old. Okay, you're getting old. So now what? Is there an option? Not really. None that I'm aware of. So, are there hurdles? Yeah, I've had my hurdles in my life, plenty of them. You can either be on the pity pot, if you will, or try to go forward and do the best you can under bad circumstances. And God knows, man, I'm lucky. I know a lot of people who got a lot worse circumstances than me.
There's evidence in the literature through interviews, investigating, that gratitude as we go through life is a really positive factor. So if somehow you can acknowledge your blessings and have gratitude, that can help your longevity.
And unfortunately, a little bit of society right now has a fair amount of negativity, if you will. And that's difficult sometimes, but you really have to blow that out of your brain. You have to keep your own mind working in the other direction. You can't listen to everything everybody says.
Right. And I'm sorry, but there are people that are truly suffering, as you're saying, and we want to help them, right? And acknowledging what is you're suffering with, whether it's spiritual, pain, medical, we can help.
One of the chapters in your book is about palliative medicine.
Yes.
Could you kind of just elaborate? A lot of people might not know what that really means.
Yeah. Palliative medicine is a specialty that rose out of the Department of Geriatrics, Mount Sinai, and other places in the nation. And it really came out of, do you remember back, and we talk about it, Dr. Kevorkian, there were people that were suffering so greatly that they wanted to die. And that was an extreme response to people suffering. So the field of palliative medicine kind of came out to address suffering. And we see suffering as we get older, often with multiple chronic conditions, not being heard, having difficulty living independently. It can be pain, it can be spiritual, it can be mood, it can be complex medical care. So palliative medicine came out of that to help people make decisions about what care they can get, should get, what are their options, what matters most to them. There's a lot of alignment, geriatrics and palliative medicine, but palliative medicine has been focused on minimizing symptoms and suffering. That's really been the niche. And it sometimes takes complex treatments to help people in their suffering phase. So I'm a geriatrician, board certified in internal medicine, geriatrics, and palliative medicine. There's some palliative medicine in geriatrics. There's some geriatrics and palliative medicine. So there's this little bit of overlap. between the two fields, but the rise of palliative medicine is described in this chapter. Diane Meyer and Rosemary Gibson were incredible interviews that describe their force, their advocacy to really address people's suffering, and it's an important story to hear.
Like to me, I see a lot of people that are suffering.
Yeah.
And pain management and mobility management and all kinds of, as you pointed out, a lot of pain hits a lot of different things. But then you try to go, and I'm not knocking any doctors with this, but a primary care doctor is typically, as you said, is restricted to 15 minutes. So you don't get into any of this. So how does somebody go about taking advantage of palliative medicine?
Well, I think it's, in an ideal world, you would ask your doctor, I'm interested in palliative medicine.
Yeah.
A lot of people still don't understand. It's a field in its infancy, right? And it's evolving. But basically, you want the question the doctor should ask, why?
Right.
What is it you're suffering with or you're concerned about that you want palliative medicine or you want a palliative approach? What is your fear? What is the issue? What is the question you need answered? And have an open dialogue about it. I have patients that have come to me, I remember this gentleman in his 90s. He's pretty healthy, robust, active. He goes, but he knows his time is limited and he wants to prepare and make this chapter, this journey, whatever he has, as smooth and comfortable as possible. So we went through what's most important, how he should talk to his family about if he's suffering, if he's has an event or something, what are his wishes. We did advanced care planning. We addressed his medications, and we went through symptoms and issues. So we took a palliative approach for this chapter with him. But he did it early.
Yeah, he prepared.
Upstream.
That's what we always say, the importance.
Sounds like me.
I was like, who is this guy? Send him over. There's another Otto out there.
No, but the difference with palliative medicine, it can be at any age and at any time of an illness. And it's when you're dealing with a serious illness. So we also had this young person come in who was excruciating hip pain and wouldn't have done well on a regular floor. We needed to attend to the pain. Ended up that pain was related to a cancer, a sarcoma, and she needed to get treatment. So having a palliative team work co-management with orthopedic and oncology helped get through treatment, surgery, and then get to chemotherapy. So that's an example how you can have a palliative approach to in a non-end-of-life situation.
So the way I see it, and you talk about revolution, it's long-term. Before, you're not going to take the current situation and make everybody into a pain management or palliative person in the medical field.
No.
But over time,
and I think
if that's the goal, I could see where things can change, and it may take a number of years.
It's training, and I think like that's, I was just sitting here, and having these kind of conversations, right? So these open conversations and these educational and trainings, is really the way. And of course, that's not something that happens, or it'd be great if it did. But I think, when I was in social work school, I always knew I wanted to work with, seniors, but there really wasn't any specialized courses in that, right? So there was one briefly, but, now I even see, I've been out 10 plus years, and, there are these more specialized courses. So I already see in that kind of world that, there is being attention that this needs to be a specialized field, and you handle it, in different ways. So I think, it's a revolution, it is.
Geriatric palliative medicine are really in their infancy, and it's not one or the other. It's both. We need to embrace this space and support this space. So anybody who wants to help us in this revolution, please call me.
Well, I think society in general has to also change its attitude towards people who are older. I think there is I'm not saying all, like there are people like you and frankly, my own family who are pretty cognizant of, you do get older and, let's try to do what we can about it. But then there's this other group of people in society who look and they're like in their 20s and they're never going to be there. So all of a sudden the people who are in their 80s are like, what's wrong with them? They don't know what this band is or, okay, so I don't know what band is. But I think in general, society has to catch up with the fact that just being older doesn't make you a misfit, if you will.
Yeah.
All right.
That's ageism, and we've got to fight that.
Right. And on that note, we could talk to you forever, Dr. Carney, but I want to mention that the Aging Revolution book can be purchased anywhere books are sold. I know it's on Amazon and different places too. It's certainly a good tool.
I can't wait to read it.
Joy. That's right. We could hold it up together. We would like to thank our guests today, Dr. Maria Carney and Kaitlin Emmert from Northwell Health. You are both so incredible in making such a difference in the aging field and just in healthcare in general. So thank you so much. I'd like to thank everyone who joined us. You're listening to Project Independence and You on LIU Public Radio.